Welcome all to this lecture. I will talk in this lecture about protein prescription in chronic kidney disease. This is my talk outline. I will talk in details about protein prescription in non-dialysis chronic kidney disease patients. And at the end of the lecture, I will highlight the protein prescription in patients on hemodialysis. Let's start by non-dialysis CKD patients. First, I want to start by the rationale for protein restriction in chronic kidney disease. Why in chronic kidney disease patients we are in need to prescribe low protein diet? Why we need protein restriction in chronic kidney disease? This is because high protein diet is injurious to the kidney and may cause progression of chronic kidney disease. High protein consumption increases amino acid reabsorption in the proximal tubule. And as you know, that amino acid reabsorption is always associated in the proximal convoluted tubule by sodium reabsorption through what is called secondary active cotransport. So with high protein diet, more amino acid will be filtered, more amino acid will be reabsorbed, which is associated with enhanced sodium reabsorption. And with more and more reabsorption of sodium and the proximal convoluted tubule, the sodium that is delivered to the macula densa will be decreased. So with high consumption of amino acids, this will be associated with increased amino acid reabsorption proximal tubule and increased sodium reabsorption at the proximal convoluted tubule with reduced sodium delivery to the macula densa. And as we all know that when sodium delivery to the macula densa is decreased, macula densa will activate the tubuloglomerular feedback. And this tubuloglomerular feedback will cause the following. Will cause afferent arteriolar vasodilatation and efferent arteriolar vasodilatation. This will cause increased intraglomerular pressure with more filtration and hyperfiltration through the glomerulus. This hyperfiltration will place mechanical stress on the glomerular capillaries, and with time, this persistent hyperfiltration with this mechanical stress will cause glomerular injury, mesangial hyperactivity, increasing TGF-beta expression and interstitial fibrosis, and with time, this will cause nephron loss and acceleration of CKD progression. That's why protein restriction in diet is nephroprotective, because with protein restriction there will be little amino acid reabsorption, little sodium reabsorption, no activation of this tubuloglomerular feedback. There is another issue rather than the hyperdynamic effect and the hyperfiltration. That's why I returned back to this image. To this figure, excessive reabsorption of amino acids from the proximal tubule, excessive amount of amino acids will stimulate fibroblast activation in the interstitium and activate also mesenchymal cells and stimulates the formation of interstitial fibrosis. That's why high protein consumption is injurious to the kidney. And now, what are the guidelines recommendations for protein prescription in non-dialysis CKD patients to prevent CKD progression? The two important and most famous guidelines in nephrology patients for nutrition are the KDIGO 2024 guidelines for CKD and the KDUKI 2020 guidelines for nutrition. The recommendations for CKD stage 3 to 5 not on dialysis as the following. The KDIGO 2024 recommended a standard low protein diet. Standard low protein diet, it is the lowest possible protein for the normal protein diet. It is the standard low protein diet, 0.8 gram per kilogram body weight per day. This is not recommended or suggested by KDIGO 2020, KDUKI 2020. However, in KDUKI 2020, they suggested or recommended low protein diet, not a standard low protein diet, but actual low protein diet, from 0.55 to 0.6 gram per kilogram body weight per day. Both of the guidelines also suggest to use very low protein diet in association with essential amino acids or keto analogs. And I will highlight the importance or the action or the benefit of essential amino acids or keto analogs in the coming slides. In the KDIGO 2024, they mentioned that you can use 0.3 to 0.4 gram per kilogram per day, in addition to essential amino acids or keto analogs, to reach total protein intake per day about 0.6 gram per kilogram per day. And in KIDUKI, they mentioned about 0.28 to 0.43, near these numbers, 0.28 here, 0.3, 0.43 here, 0.4. Again, with keto analogs or essential amino acids to meet 0.55 to 0.6 gram per kilogram per day. It's important to mention that using a very low protein diet can be used in patients who have the will to use this very low protein diet and they are not at risk of malnutrition. So you have to consult your patients about this very low protein diet, and the patient must has the will to use this very low protein intake, and the patient must not be at risk for malnutrition. Actually, you cannot use low protein diet or very low protein diet in patients at risk of malnutrition, as I will mention now. Add on to this, the KIDUKI 2020 mentioned that in general in diabetics, you have to use 0.6 to 0.8 gram per kilogram per day. This is more than the low protein diet, from 0.6 to 8 gram per day in any diabetics, because they consider diabetic patients are always in hypercatabolic state. That's why these recommendations are not for diabetic patients. They recommended KIDUKI 2020 for diabetic patients to use 0.6 to 0.8 gram per kilogram per day. As I mentioned, avoid low or very low protein diets in metabolically unstable patients. Examples for metabolically unstable patients: sarcopenic cachectic patients, patients in active inflammatory or infectious state, patients who are hospitalized, early post-operative period, consumptive diseases such as cancer, patients who are on antibiotics, patients who are on immune suppressive medications, if there is significant short-term loss of body weight, and finally poorly uncontrolled diabetes. Poorly controlled diabetes. I mean uncontrolled diabetes, okay? So these are the metabolic unstable patients that you have to avoid low protein diet or very low protein diet, because they are considered in unstable state, hypercatabolic state, so they are in need of higher protein consumption. So we discussed till now the rationale for protein restriction in chronic kidney disease patients, guidelines, recommendations. We mentioned that we can use low or very low protein diet. So which is better, low or very low protein diet regarding the progression of chronic kidney disease? We mentioned that we can use low protein diet as mentioned by KIDUKI, or very low protein diet as mentioned by KIDIGO and KIDUKI. Regarding the effect of CKD progression, which of them delays the progression more? This is one of the most famous systematic reviews and the meta-analysis of studies that studied low protein diet in CKD patients. This graph shows the comparison between very low protein diet and low protein diet regarding risk of progression to end-stage kidney disease. As you see, that the results of this meta-analysis favors the use of very low protein diet. The risk of progression to end-stage kidney disease was lower with very low protein diet. Also, the GFR decline was less in patients with very low protein diet. So it seems that very low protein diet is more effective in delaying CKD progression than low protein diet. But again, must be used in patients who have the will and who understand well the effect or the rule of the consumption of very low protein diet. Regarding the use of keto analogs and essential amino acid supplementations, as I mentioned, that if you used a very low protein diet, you have to use essential amino acids or keto analogs in both the KDIGO and KDOKI guidelines. The main idea of using essential amino acids or keto analogs is to avoid malnutrition in these patients, because you prescribed a very low protein diet in these patients. So if you didn't supply essential amino acids or keto analogs with this very low protein diet, the patient will progress to malnutrition, which may be a factor of progression to end-stage kidney disease. Malnutrition is one of the factors that facilitates the progression to chronic kidney disease. So you have to avoid malnutrition. That's why we are supplying essential amino acids or keto analogs. Essential amino acids and keto analogs themselves don't delay the progression. We mentioned in the previous meta-analysis that very low protein diet delays the progression of chronic kidney disease more than low protein diet. But this is not because of the use of essential amino acids or keto analogs. The delaying of progression is better in very low protein diet because of the more protein restriction, not because of essential amino acids or keto analogs. Essential amino acids or keto analogs themselves there is no evidence till now that they are affecting progression, but their use gives you a good room to use a very low protein diet, which is very effective in delaying the progression of chronic kidney disease. Regarding the dose of essential amino acids or keto analogs, if you use them with very low protein diet, you have to supply the patient with 1 tablet per 5 kg of body weight per day, divided in 3 doses, and give them with meals. This is a very large dose. 1 tablet per 50 kg. Suppose that if the patient is 50 kg, so you have to give him 10 tablets. Some experts, this is not a guideline recommendation or suggestion. Some experts use keto analogs or essential amino acids with low protein diet in the dose of 1 tablet for every 8 to 10 kg body weight of the patient. They are using these tablets, essential amino acids and keto analogs, in patients on low protein diet and at risk of protein energy wasting. But this is an expert opinion, and there is not a guideline, suggestion, or recommendation. What are the main pitfalls of keto analogs and essential amino acids? These tablets are in the form of calcium salts. They may cause hypercalcemia and gastrointestinal discomfort. But at the same time, because they contain calcium salts, they may act as a phosphate binder. And again, for sure, the high pill burden, as you see, in the very low protein diet, you have to give the patient 1 tablet for every 5 kilos from his or her body weight. This is a very large dose. The last point, in non-dialysis CKD patients, protein prescription non-dialysis CKD patient, is the use of plant-based food. In the past, low protein diets was done by using at least 50% of animal origin, but the new evidence supporting the use of higher consumption of plant-based food, plant protein, not animal protein. Plant-based diets must be is in the form of using more plant-based food and the use of animal-based food in moderation. The most famous is the BLADO, plant-dominant low-protein diet. You have to use more than 50% of the protein to be of plant-based source. Why the plant-based food is now highly suggested? Because it has a lot of benefits, but again, it also has some potential challenges. The benefits of low protein diet with more than 50% plant sources have the following advantages: lowering intraglomerular pressure, synergistic effect with RAS inhibitors and SGLT2 inhibitors, controlling uremia and delaying dialysis. Uremia is more common with animal protein than plant protein, preventing cardiovascular harms of meat, less adsorbable phosphate from the plant protein. Lower acid load. Plant protein has lower acid load. High dietary fiber, which enhance gastrointestinal motility. Favorable changes in microbiome in the gastrointestinal tract. Less TMAN oxide, leading to less kidney fibrosis, and finally less inflammation and oxidative stress. So the using of plant source has a lot of advantages, but it has also potential challenges, especially if it is used with in the form of low protein diet. First, there is a risk of protein energy wasting, inadequate essential amino acids, undermining obesity management, high glycemic index, high potassium load, and hyperkalemia, and this is the most important from my point of view. Less palatability and adherence, inadequate fish intake if vegan, with less supplementation with omega supply. So these are the current evidence supporting the use of low protein diet in patients who are not on dialysis. Regarding patients on dialysis, we will increase the protein intake because dialysis itself is considered as a hypercatabolic state, but at the same time we have to take care of high phosphate burden and hyperphosphatemia in these patients. The KDOQI 2020 guidelines recommended the following regarding the protein intake in patients on maintenance hemodialysis. First, in non-diabetic or diabetic metabolically stable patients, the recommended protein intake per day is 1 to 1.2 gram per kilogram per day. In diabetics with risk of hyper and or hypoglycemia, high levels of dietary protein intake may be needed to be considered to maintain glycemic control. So these are the available recommendations and suggestions for CKD for protein prescription in CKD patients. Thank you for watching the lecture.